Good morning, everybody, and welcome to the Myocarditis family Zoom call meeting. I do want to give a little disclaimer ahead of time that I, like many of you, are learning Zoom on the fly. We have not had many meetings, and please forgive me for any technical difficulties ahead of time. We'd like to thank you all for taking your time on this Saturday to be here with us. The meeting was made possible by our sponsor, the Trilogy Group at Morgan Stanley. I'd like to introduce myself. I'm Genevieve Ramori. I'm a registered nurse with more than 45 years of experience, many of them in cardiac and emergency room nursing. I have been with the Myocarditis Foundation as the executive director for 6 years. My husband is a viral myocarditis survivor who had a heart transplant over 14 years ago. He has been a member of the Myocarditis Foundation Board of Directors since 2007 and is its current president. He and a few other board members have joined us on the call today. Today is very exciting. We have more than 83 participants from 6 different countries. All have been sadly affected in some way by myocarditis. We hope that you are comfortable and have your morning or afternoon beverage of choice, depending on what country you are in, with you, so you can listen to our esteemed cardiologists and researchers reply to the questions that you have sent in. I have given the questions that you have sent to the panel. They will share in the answering of them. The doctors and researchers will try their best to give you as much information as they can without getting specific to each of your cases. Please keep in mind that this cannot be a personal consultation. Please write any additional questions that you may have on the chat screen, and we will attempt to answer as many of them as we can. Keep in mind that this may be likely that another person has already submitted a similar question that the panel has and will be already discussing. I'd like to now share the doctors' pictures so that you have an idea of who is who. Okay. Let me get this out of here. Okay.
It's not.
Uh-huh.
It's not on there.
What's not on there? Can you see?
No,
Share.
don't worry about it. Just go back. Minimize that and don't worry.
Okay. Like I
Just start talking
said,
about it.
share screen. Just gotta.
So we go, you're on Zoom. Now get that picture. There we go.
Okay. Can you all see the
Yes.
doctor's pictures?
Yes.
Okay. All right. I'd like to introduce our esteemed panel of cardiologists and researchers from our Board of Directors and Medical Advisory Board. Dr. Leslie Cooper is an adult cardiologist and researcher whose specialty is myocarditis and giant cell myocarditis. Dr. Cooper is world-renowned for his research in giant cell myocarditis and is frequently consulted by doctors from around the world on the disease. He is the chair of the Enterprise Department of Cardiovascular Medicine at the Mayo Clinic. He is co-founder of the Myocarditis Foundation and has been the foundation's medical director since 2005. Dr. Jack Price, a pediatric cardiologist at Texas Children's Hospital, he specializes in myocarditis, heart failure, and transplant cardiology in children. He has been a member of the Myocarditis Foundation Board of Directors since 2014. At Texas Children's Hospital, he initiated and was the director of the first ever pediatric-specific heart failure intensive care unit, where he has treated many cases of myocarditis. These children and their parents travel there from all over the world to receive this specialized care. Dr. Bettina Heidecker is an adult cardiologist and head of the heart failure and cardiomyopathies at the prestigious Charité, I'm sorry if I mutilated that, Bettina, University of Medicine in Berlin, Germany. Dr. Heidecker is also a researcher of myocarditis and was one of our first Myocarditis Foundation Fellowship Grant recipients. She has been a member of our International Medical Advisory Board for 4 years. Dr. Delisa Fairweather is the Director of Transitional Research for the Department of Cardiovascular Medicine at the Mayo Clinic. She has been a devoted researcher of myocarditis, who has been with the Foundation's Board of Directors initially since 2011 and later with the Foundation's Medical Advisory Board since 2019. In early 2020, after we first heard the word COVID, Dr. Fairweather received a $26 million research grant for the development of the COVID-19 Convalescent Plasma Expanded Access Program. Well, now that you have heard about who our prestigious panel is today, I'd like to explain how we will proceed. We have organized your questions into 4 groups: COVID and COVID myocarditis, pediatric myocarditis, viral myocarditis, and giant cell myocarditis. The panel will work collaboratively on answering your questions and any additional ones from the chat screen as time will allow. Dr. Cooper, I offer you the first question.
Jen, thank you so much. First, I'd like to acknowledge Jen, Joe, and Melissa, who have done all the organization for this meeting. There's a lot of background work that needs to go into something like this, particularly on an international scale. And I really want to recognize them for their hard work putting this together, and also to thank my co-presenters who have taken time from their Saturday. And I think it's Saturday throughout the world right now, perhaps not in Asia, to thank you, both our attendees and our presenters, for taking a couple of hours from your day to be with us. We've received a substantial number of questions ahead of time, and we're going to try to answer those systematically, each of us taking 2 or 3 and going in turn. We're then going to take a break at about the 30-minute mark and the 60-minute mark to answer any questions that you send in by the chat. So I'm going to start with COVID-19 questions. And the first 2, which we received, are: am I at higher risk of developing COVID-19 since I had myocarditis? The answer is your susceptibility to COVID-19 is not known to increase only because you had previously had myocarditis. It's possible if you had a severe cardiomyopathy that you might be at the higher risk of developing complications should you get the virus. But the susceptibility to the initial infection does not change that we know of. The second question: how can you differentiate between COVID-19 and COVID-19 myocarditis? That's a great question, because the symptoms of pulmonary infection or systemic viral infection that you would get from the virus could be very similar to those symptoms that would be attributable specific to the heart. And so what we say is, in people who have chest pains or particularly trouble breathing and are under the care of a physician, it's reasonable to get an EKG and a troponin level, which is a blood test to look for damage to heart muscle in that clinical scenario. We have not recommended that, or the American College of Cardiology and other relevant professional societies haven't recommended routine testing for asymptomatic infections. But in symptomatic infections, then, and particularly those people who are in the hospital, there is a role for an EKG and troponin. With that, I'd like to hand it to Jack for the next 2 questions.
Great, thank you, Les. I'm going to pick up on a couple of pediatric specific questions. The first I'll read is, my 13-year-old son was diagnosed with viral myocarditis by MRI in August. His echoes and his EKGs have always been good. They won't do another MRI though until next August. We have no way of knowing what is happening in the interim, and it is a long time to wait. He is not on any meds at this time. So I'll say that a follow-up MRI is becoming more and more common among pediatric patients who've been diagnosed with viral myocarditis. It's still a relatively new mode of diagnosis and follow-up for myocarditis in children, and we don't have a lot of long-term data on this to help us and to guide us. I would say that in general, most physicians caring for children with myocarditis are doing a follow-up MRI now at about 6 months after the initial presenting MRI. I would say in reading this question, though, I'm reassured by a few things. One, the questioner is saying that the echoes and the EKGs have always been good, and To me, that means the cardiac function or the contractility of the heart muscle or the size of the heart is normal, is my takeaway on that, and that the EKGs have not shown any evidence of damage to the heart muscle or any kind of arrhythmia or dangerous heart rhythms. So those are reassuring features in this case, and that's probably what's leading the physicians to wait a full year. You know, I would probably just talk to them about that and see what their rationale is for that. In general, I'd say most follow-ups are at about 6 months. I'll move on to another question here related to familial tendencies and genetic links of myocarditis. And, you know, Delisa, if you want to jump in, if you have some additional information on this, that might be helpful. In general, we don't think of myocarditis as a genetic disease. At least let me just say this, viral myocarditis, as it pertains to children. You know, there's not a known gene that we test for in these patients. There are reports of clusters in families, although they're exceedingly rare. I myself personally have not seen it within a family. If I were to have a family with multiple members who were concerned about myocarditis, I would probably expand my diagnostics to look for other diseases as well. For example, cardiomyopathies, dilated cardiomyopathy, a form of cardiomyopathy called arrhythmogenic right ventricular cardiomyopathy, which may sometimes mimic viral myocarditis on MRI. So I'd probably be doing some genetic testing in those situations. But there's not a specific genetic test that we have that we use routinely for myocarditis. And Delisa, I don't know if you're aware of anything on the horizon for genetic links that can be tested for in families.
Yes, thank you, Jack. So actually, we have just been recently received some funding to start to look at this. So through really connecting through Jen Ramore, basically a number of families have sort of connected with us where they have had reports of more than one family member that have had what appeared to be viral myocarditis, which is very unusual. We had never really come across this before. And it seemed like just amazing that all of a sudden patients seem to just be coming in and reporting this, you know, all at the same time. And so we were really interrupted by COVID-19 and me being in my lab becoming involved in the expanded access program, which took all of our time and energy. But we are now that that's calmed down a bit, we are about to reinitiate looking at this. So we have a number of families, and so the plan is to do genetic analysis and really look at the cases and see if we see anything going on genetically. And of course, the important aspects that you brought out, Jack, about other things that might mimic would be there. We do know it's most widely reported for dilated cardiomyopathy. It's known that there are a number of genes that have been associated with the development of cardiomyopathy or dilated cardiomyopathy. So we would look at that. But as far as I know so far from a little bit of information from the families is that they don't appear to know of any mutations in their family. And so it would just be interesting to see if we find a mutation and if whether it was something maybe mild enough that it required a viral infection to really cause it to present. But all of that will be ongoing and we'll see. I know that there in England, in the UK, there has been some publications where they're starting to look at whether there could be a link to myocarditis and genetics, and but they haven't found actual myocarditis patients. They've more just been screening cardiomyopathy patients and sort of more hypothesizing that direction. And the only other comment that I would make is that I do think that there is, when we look at our research in animal models, that we do see susceptibility to whether you're going to get dilated cardiomyopathy that doesn't have to do with a mutation, but does have to do with genetics. And that has to do with really whether you have more mast cells or not, and sort of your background, like whether you're Caucasian or whether you are more dark-skinned nationality, and that whether that's going to result in a more fulminant form of myocarditis versus a mild form that may progress to dilated cardiomyopathy. So we see very clear differences there that are genetic, but not like a mutation per se. So those are all areas that, we're working on researching that could help us understand the disease better going forward.
Okay, great. Well, I'll hand it off to my colleague, Dr. Heidecker.
So, yeah, I have the question here from the top again on COVID-19. Do you anticipate a surge in myocarditis with COVID-19? Overall, experts agree that it seems to be rare in COVID-19 patients, myocarditis. There has been an autopsy study that has shown that myocarditis was very rarely found. What we do see is acute cardiac injury, so elevation of troponin, which is a protein that gets released when there's injury of the heart muscle. But myocarditis per se is rarely found. What we've seen in our registry at the Charité in COVID-19 patients is that troponin is usually elevated in patients who are severely sick, so patients in the ICU or those who need mechanical circulatory support. And that has also been shown in the literature that it's a poor prognostic factor. But myocarditis itself is rarely found. So I don't anticipate a surge, but likely we'll see some long-term complications in those patients who had cardiac injury that could be a logical consequence from the injury, that they may develop heart weakness, heart failure. The next question is, how can COVID-19 affect someone who has myocarditis? So if the patient had myocarditis in the past, Dr. Cooper already answered that would not really, there's no data how that affects susceptibility. We don't think that it increases susceptibility. Somebody who has acute myocarditis and gets on top of it COVID-19, I haven't seen. And that maybe also answers the next question. Any patients with myocarditis who have later developed COVID-19, I have not seen any. So yeah, also because it's rare, I think the likelihood that this comes together is just so low. I haven't seen that. And it seems like the patients with myocarditis don't have a specific predisposition. Yeah. Good, then I would like to hand over. Sorry, somebody wanted to add.
And I just add,
yeah, of course.
A number of people who have, if you're following the literature on COVID-19, know that about 50 or 60% of the older patients who've been hospitalized 2 or 3 months down the road still have shortness of breath or fatigue. And that post-COVID syndrome is multifactorial, meaning that it's not always due to a heart problem specifically. It could be there's some pulmonary injury left over from the lung infection, or there could just be deconditioning related to the hospitalization. And in some patients, there may be changes in the heart muscle related to the virus, but it's multifactorial. So it's important as you read more, as we get further and further into this pandemic, and there are more and more people who are recovered, so to speak, or more and more time has elapsed since the hospitalization, there's going to be a cohort of people you read about. But the message today is that there are multiple reasons for that clinical experience of shortness of breath and fatigue besides the heart.
Absolutely agree.
Please.
And the patients
just
that
adding
I've
a little
seen,
comment at the end there.
yeah, and the patients I've seen in clinic with persisting symptoms, usually, as you say, it was pulmonary, so it was not from the heart. Yeah, it was just residual pulmonary damage.
Yeah.
Okay, then we'll
Delisa.
do the next. Yeah.
Yeah, so I'll go to the viral myocarditis questions. So the first one was, I was told that I had scarring on my heart from myocarditis. Will the scarring ever go away? So of course I'm speaking as a researcher and not as a physician. So we can always have somebody else give that input after I give my perspective on it. But from a research perspective, we look in animals where we give the virus, a common virus that can cause myocarditis. And in that model, mice, we have discovered that the immune cells that go into the heart during acute myocarditis is what leads to what we call remodeling and fibrosis, and that is the process where scar is laid down in the heart, and then that takes some time, and when that scar develops, then that leads to cardiomyopathy or the dilated cardiomyopathy. And so your question of whether the scar will remain, or let me look at the question again. Just like whether the scar, what's true about scars, no matter where they are, whether they're in the heart or anywhere else in your body, scar tissue is very difficult for it to go away. And this has been a very avid area of research. And one of the areas that myself and Leslie Cooper are very involved in. It's a new area called regenerative medicine. And we are looking at actually release these little vessels. They're called extracellular vessels. They're kind of like little tiny bubbles, I guess, that release off from cells. And they really are messengers in the body, and they can have healing properties about them. If a person is healthy and they release these sort of messengers in the body, they can have quite healing properties. And so what we have been doing is we're able to get these extracellular vesicles from the blood or from adipose tissue and fat tissue, and then put these into animals, and we've been able to show that they can decrease not only the inflammation, but they can also decrease the scar. So this is ongoing research. We haven't published it yet, but we're still working on it. So it's very promising that there may be something that will actually be able to reduce scar going forward in the future, although we don't really have medications currently that can do that. But many different researchers are working on this for many different diseases, and it looks quite promising. So that was the first question. And then if someone has moderate scarring after viral myocarditis, what's the long-term outlook in terms of future cardiomyopathy? So it really, again, very similar to what I just described. The less amount of inflammation you have in your heart, there's a direct relationship from our animal model with how much inflammation you have and the type of inflammation and how much scarring you end up getting. And then that's directly related to how severe the dilation is later. Unfortunately, in patients, that can be very difficult to ascertain. It's much easier for us to tell that in an animal. But I think the lower the amount of scarring that you have, I would say that there's, less severe cardiomyopathy very likely that you would have. So that would be hopefully a good indicator, I would say. And I will pass off to Leslie, and I don't know if anyone else wanted to add a clinical perspective to what I was just saying.
I think you did a great job with that, Delisa. Thank you so much. And I want to thank all of the participants who sent in their questions. There's a wide variety of questions, both related to children and adults and survivorship. And we're going to cover a lot of ground here, both from a scientific and a clinical standpoint. So thank you for sending in all these questions ahead of time and letting us think about them to give you the best possible answer. I'm going to take giant cell myocarditis, and there are quite a few questions. I'm going to group them together. The first couple are there any new studies being done in giant cell myocarditis? The answer is yes. Our last paper was 4 weeks ago. in the International Journal of Cardiology. And that study focused on patients who require mechanical circulatory support. These are devices which either through the arteries or implantable devices are used often as a bridge to recovery or a bridge to transplant for people who cannot supply blood to their body with the heart pump alone. And we showed in that study, which was a review of the published world's literature, that if you give immunosuppression early before a device is needed, that the likelihood of a bridge to recovery and survival overall was better. That's a controversial area because there's an increased infection risk of the device, but at least with temporary devices like an Impella or a balloon pump, it appears that immunosuppression ahead of time is useful in that group. So that's a recent study. We don't have any active trials ongoing for treatment other than these descriptive studies. The second and fourth question, what are the long-term outcomes in survival and what is the longest survival known for GCM? To my knowledge, 23 years is the longest GCM survivor in my practice, someone I personally have cared for. And there are a number of people at 20 years and beyond. The survival outcomes are, from our data, 90% overall survival at 1 year and 77% transplant free survival, meaning about 20-some% get a transplant in people who are diagnosed 3 weeks from symptom onset and treated within 4 weeks of symptom onset. The data from Finland, from Rina Kandelin and colleagues, is similar, but both support the idea that you need to make the diagnosis really early. If you suspect giant cell, the doctor should be doing a biopsy and looking for giant cell as soon as possible. I'll add one question here. What about physical activity? And like all forms of myocarditis, when there's acute inflammation, we recommend abstaining from sustained aerobic activities such as competitive sports or long distance running. We do recommend for all forms of myocarditis continued activities of daily living, and then activity, and then gradually building up after the inflammation is gone. Jack, I hand it back over to you.
Okay, great. Thanks, Les. I am going to answer some questions about the vaccine. We didn't have a whole lot of pediatric questions, but just a few. And one of the pediatric questions is related to the vaccine. The question is, what about teenagers taking the COVID vaccine? Well, you may have heard that the COVID vaccine excluded patients under age 16 years when they were studying its efficacy and safety. So the FDA has not approved it for patients under 16. For patients 16 and above, we are recommending it. I'm recommending it. My patients will eventually be receiving it. Even those patients with underlying diseases, including heart failure. This leads into another question about the vaccine. Is it safe, especially after having had myocarditis, and especially because it causes an inflammatory response in the body? Is it safe? Well, the COVID vaccine in its studies for safety was administered to, about 60,000 patients were enrolled. And the safety profile was strong. The side effects were exceedingly low, and the serious adverse events were very, very low, causing it to be approved by the FDA. It's now been administered to close to 7 million people. I read a couple of days ago that there were reports of 21 individuals who had severe anaphylactic reaction, which is a severe allergy to the vaccine. That number is exceedingly low in the presence of 7 million patients receiving the vaccine. In its relation to myocarditis, I probably wouldn't be administering it in an acute, episode of myocarditis when the body is revved up and inflamed, but more likely later on when the patient has recovered. This vaccine was studied not only in healthy people, but also in sick people with lots of different comorbid conditions like heart failure, diabetes, pulmonary hypertension, coronary artery abnormalities, even in patients who have HIV, and found to be safe. We are recommending it on the pediatric side to our patients above 16 years of age, and I'll defer to my adult colleagues about their recommendations on the adult side, but we feel very safe and confident in administering it to our pediatric patients. Were there any myocarditis patients? Oh, sorry. Go ahead, Les.
Very briefly, I spoke on Monday to somebody who works at CDC in Atlanta, and of the first 3 million doses that were administered, there were no cases of myopericarditis, he said. So again, I think it's a very low risk of myopericarditis.
Were there any myocarditis patients included in the COVID vaccine testing? There were heart failure patients who were included in this study, but they didn't give us any additional information beyond, what was the actual cause of their heart failure. So I'm not aware of that. I'll pass it on to Dr. Heidecker.
Okay, then I'll continue with the next question. Would there be any concern with the vaccine if one is on immunosuppressants, steroids, and other heart medications? So in general, when a patient is on immunosuppression, the important thing is that the patient doesn't get live vaccines, but those mRNA vaccines, they are not live vaccines. So that by itself is not a problem. What we know from patients who are immune suppressed is that the immune response may not be as strong because the immune system is suppressed. So the efficacy may be somewhat reduced, but still the benefit is there. So we recommend, and I let the other ones, my colleagues also weigh in, but for mRNA vaccines or inactivated vaccines, I don't see any contraindications. I'll let my colleagues also weigh in on this one.
No contraindications.
Okay, and check also.
Yeah.
Okay, then I'll go back up, and there was also a question on when is it safe to exercise after COVID myocarditis and pericarditis. I would say it's the same as for any myocarditis. We recommend 3 to 6 months of reduced exercise, just very low exercise level due to the risk for arrhythmias. And yeah, that would be that. Okay, Delisa, would you like to continue?
Yes, so actually I will just follow on from a research standpoint with the exercise component, because we are doing exercise and received a grant from NIH to look at how exercise affects myocarditis. And although we have these recommendations and we do know that it can cause arrhythmias, really there has been no research in animal models to understand what is going on and how it affects the inflammation and what could be causing the arrhythmias. And if that has to do, there's a number of different hypotheses with different receptors that might be activated, if the cytokines might be causing it. And so we actually are able to exercise the mice on a treadmill and do the same stress echoes that you would receive as a patient with our animals. And so that is studies that we are doing. So hopefully we will gain insight so that these recommendations, if we can work out really what the mechanism is, then we might be able to provide medication that would help understand this better. So, we wouldn't have just this blanket recommendation, which really is not based on any specific data, interestingly enough. So that's part of what we're trying to work on, because it's a very important question, especially as many young adults are affected with viral myocarditis. And this can really affect them, and athletes are affected. One of the other areas that we're working on is related to the expanded access program. So this is the program where we gave convalescent plasma to patients with COVID-19, which was involved in. And one of the offshoots of research that we're doing in my lab is we're looking at how viruses can attack the heart. And we have found that one of the main ways they do it is to attack mitochondria, which make the energy in all of our cells. And really they go in and attack the heart that way. And so we are interested to see what is happening in relationship. So we were able to get samples, so the convalescent plasma samples, and we want to analyze those samples and see what might be happening. And part of what we plan to do is take convalescent plasma and extract out those vesicles I talked about earlier and see what they are doing in the heart in the animal model where we're looking at myocarditis, and also to look at patients and what their outcomes in this study were for cardiovascular outcomes and anything that looks similar to myocarditis, or as was mentioned before, viral induced heart damage. So we're going to be dissecting those different aspects and whether the convalescent plasma helped, didn't help, and what possible mechanisms it might be using to help. So those are all things going forward that may shed more understanding on, from a research standpoint, some of the things going on in relationship to COVID-19 and how it can affect the heart and how it can affect people with myocarditis or that develop myocarditis as a result of COVID-19. And I think I'll pass it then on to Leslie.
Well, Jen, have we, it's been about half an hour since we started. Have we received any questions on the chat?
Well, there is one question, but it's in the questions already, I believe, for the giant cell. The question was, with giant cell being an autoimmune disease, is there any additional concern regarding the COVID vaccine and how it interacts with the immune system? So I think you may have replied to that already. And then we just got, I'm sorry.
And I'd agree. My recommendation is that if you've had myocarditis, like Jack said, once you're over the acute illness and you're not symptomatic, to get the vaccine. I think that even if you've had COVID-19, the antibody response to the vaccine is better than you get to the natural infection. And so even people who've had previous COVID infection, we recommend getting the vaccine, not when you're acutely ill, but when you recover.
Right.
And then, I'm sorry, Jen, next.
And then there was a question asking about what Dr. DeLisa was talking about when she referred to the bubble-like messengers in the body, in regards to healing scar tissue. The person said, is that stem cell regeneration? And if so, is that being made available yet?
Yes, so that's a very good point. So yes, stem cells have been being studied as part of regenerative medicine. And what we have found is that the stem cells actually release these extracellular vesicles that I'm talking about. And that's why stem cells have been effective. And so there's kind of been a shift in the field to actually look at the vesicles rather than the stem cells, although people are still exploring stem cells also. So both of those areas are being used as part of trying to understand regenerative medicine. And I think for some types of heart disease and other diseases, some of these products are in clinical trial stage.
Okay.
And I'd like to point out one of our researchers, Caitlin Bruno, won the Young Investigator Award at the European Society of Cardiology in 2019 for her work using these exosomes, as they're called. Pretty cool, very prestigious award. Caitlin's not on the call. I don't know if Caitlin's on the call, but congratulations if you are or not.
Okay. There's one more question, and then I guess we can go back to the routine questions people had sent in. They are asking for a explanation of viral myocarditis versus giant cell. I think the person is unsure if giant cell is a viral myocarditis or if it's a different type of myocarditis.
Sure. Briefly, the vast majority of giant cell myocarditis cases are not associated with a viral infection. There have been a few isolated case reports, one from Korea, South Korea, which look like there could have been a viral trigger, and that the giant cells were a manifestation of a very severe reaction to that virus infection. But the vast majority, way more than 90% of giant cell infections are not associated with a specific identified virus. It's more of an autoimmune reaction.
Okay, thank you very much.
Jen, do you think, shall we go back to the another cycle of questions from the list, and then do, I see a lot more questions are coming in through the chat. We can, as we're getting them, maybe organize them. And then,
Okay.
what do you think?
Sure. I'll start organizing them, and then we can take another section of
Okay.
time. Okay.
Well, I'll just do very briefly a couple more giant cell questions. There are two transplant-related questions. The first is in transplanted patients, is there a way to diagnose recurrent giant cell myocarditis prior to symptom onset? The answer is we have in the native heart recurrence, which is about a 12.5% overall recurrence rate, or in the transplanted heart, where it's described between 20 and 25% recurrence overall. In the transplanted heart, where sometimes we do surveillance biopsies, giant cell has been picked up before symptoms on biopsy. It could also be picked up by an increase in some blood markers, such as natriuretic peptides, BNP or NT-proBNP are examples of natriuretic peptides, which can elevate prior to symptom onset. Certainly in the native heart, which is analogous, I guess, to the transplant, in that the recurrence can have an asymptomatic phase. I've seen patients with a marked elevation in natriuretic peptides before they become symptomatic. So the short answer is yes, we do surveillance echo in people who've had giant cell myocarditis, even if they have no symptoms when they've recovered. And there are similar protocols in the post-transplant setting for surveillance, not always with biopsy, to look for early symptoms. Now, the second question is, what about steroids in the post-transplant setting? And that is empiric. We tried 20 years ago to write a paper looking at the optimal management of patients after transplant for giant cell myocarditis. And the challenge was enormous because we couldn't get detailed data on immunosuppression from enough cases across the world in order to write the paper. We tried very complex number of challenges sharing data. So it's empiric. We don't have a trial, but we feel that, and to be honest, my personal recommendation is that people follow their standard site-specific post-transplant medical regimen, and then just be mindful that there's a 20% chance of recurrence in giant cell. But in the absence of data, I don't think we uniformly use steroids. And then let's go on to Jack.
Okay, thanks, Les. I'm going to pick up again on the vaccine, some of the questions related to that. Would there be any concern with the vaccine for someone taking immunosuppressants, steroids, or other heart failure medications? Generally speaking, I would say no. Initially, when we were first learning about coronavirus and its mechanisms of entry into the body, there was concern about whether or not patients should stop their ACE inhibitors. We've concluded that it is safe to continue those medications, which are heart failure medications. So definitely continue those. We have transplant patients, for example, who are receiving immunosuppressants, and some of whom are receiving steroids. The International Society for Heart and Lung Transplant is recommending that transplant patients who are on these medications receive the COVID vaccine. It is in their best interest to receive that vaccine. Now, I would just place one caveat on that by saying that it's probably not wise to give it immediately after a transplant or in that acute recovery phase. But I think that once the patient is, several weeks out from the transplant, that it's safe. Again, you should talk with your physician though, and find out exactly why you're on these immunosuppressants and what they're doing to your immune system, just to have a better handle on the safety of receiving a vaccine. But in general, it is thought to be safe, and it is recommended by our transplant societies. Is there any reason to believe that COVID vaccine can cause myocarditis? Well, we heard some great insight from Les about that, and his answer was there's no evidence that patients who receive this vaccine go on to develop myocarditis thus far. So that's good news for us. Is the flu shot safe for someone with myocarditis? Yes, I would say that the flu shot is safe. Again, I think it depends on what phase of the illness you're in. If you're in the acute inflamed stage, I'd probably hold off until you're convalescing. But in generally speaking, yes, the flu shot is safe for patients who have had myocarditis. Dr. Heidecker.
I'll move on. It's under pediatric patients, but it also applies to adults. It says, are there any medications that can help scarring of the heart to heal? So we have medications that we also use in general heart failure or cardiomyopathies, which are ACE inhibitors or ARBs. Those medications are known to prevent remodeling, which means that they reduce the risk of functional tissue to get replaced by scar tissue. Also, eplerenone and spironolactone are medications that reduce the risk of scarring, similar mechanism. And those are applied when the ejection fraction is less than 35%. So they have specific indications. There's some research data that those also have anti-inflammatory effects. So they also reduce inflammation. And also beta blocker have some anti-remodeling effects. So also those reduce the risk for scarring. And of course, when there is active inflammation and there is an indication for immunosuppression, that by itself is the most important factor to reduce the risk for scarring, because inflammation, chronic inflammation, usually leads to some scarring after some time. And then another question I found here is, do survivors report residual chest pain? Very often. So yeah, I see it very often in patients who had myocarditis, that for a period of about 1 year, they still feel sometimes chest pain. They describe it like a gripping chest pain, like a hand like holding their heart and pressing from outside together. So a little bit different from what patients with heart attack describe to us, where they usually more describe a pain where they have an elephant sitting on their chest or pressure from top of their chest. In myocarditis, what patients more frequently describe to me is that, that they feel like their heart is in a hand and the hand grips together. Usually lasts for a few seconds, comes on without any specific triggers, and disappears within seconds. So of course there are individual differences, but overall that's what I've observed. And they can last about a year still and then resolves usually spontaneously. Patients are of course concerned, but there's no data that shows that patients with those ongoing symptoms have a worse prognosis, as far as I know. And I let the other ones also weigh in. Leslie, if you want to add also. Yeah.
I agree.
Okay, good. Then I hand it over to Delisa.
Okay, I see a research question. Sorry. Is there any research on the long-term effects of myocarditis? And I would say I have not really seen research that has gone out years in an animal model. We have gone out quite far. And what we mainly see is you go from myocarditis, then you develop dilated cardiomyopathy and susceptible animal strains, and that whatever level of disease sort of develops, depending on the circumstances that we've created in the lab, then that just, if without any intervention, that just persists and it doesn't change as far out as we've looked. And so that's where we would need to intervene. And so certainly the way that we have set this animal model up, which in every parameter that we've looked at so far and compared it to humans, it is matched. So we think we have quite a translational animal model. That is what we see as far as the long-term effects. So we definitely want to intervene going forward as we develop ways to intervene, as Bettina has described some medications, and as we think of innovative new therapies that also may decrease inflammation remodeling. If we can intervene earlier to prevent progression to dilated cardiomyopathy and long-term effects after acute myocarditis, that's what we really want to, develop and improve those kinds of therapies. As far as, I saw another question here. My husband was sick with parainfluenza for 3 weeks before he died, and we found out then that he had viral myocarditis. Is this something that could have been diagnosed before it was too late? And I think regardless of what the infection is, the really difficult thing is most of these viral infections, if it's influenza, if it's Coxsackie virus, these viruses often can give you a relatively mild disease or something that it just feels like a common enterovirus, a common stomach flu, a common respiratory infection. And so you don't realize that this infection has gone to your heart and that you are at increased risk. And so even when you go to the doctor, there is often not a clear indication. Often there isn't any immediate symptoms that you're having a problem with your heart. So this is what has made viral myocarditis extremely difficult to catch and realize that there's a problem often until it is too late. So I would say in most cases, that's been the challenge. It's very difficult to know that you have a problem with your heart until you're really at a crisis very often.
True.
And I will pass it on then to Les.
Jen, I see we've received a number of questions. Would
Yes.
you like to pass them out to any of us?
Well, there is two COVID, one a vaccine question and one just in general. If there is an mRNA versus another type of COVID vaccine, and I don't think the other COVID vaccine is approved yet, would you recommend one over the other?
No, we don't have any data.
Okay.
Yeah, I would take the first one that's available.
Okay. And is there an increased risk of developing acute myocarditis viral again if you have the COVID, if you develop COVID? So you
No.
had myocarditis, you got COVID at some point, and is there an increased risk of developing myocarditis again from the COVID?
So
No.
even though we don't know whether the 3 million people who got the vaccine that I heard from CDC on Monday had myocarditis, undoubtedly some of them did, because it's common enough that you would have picked up recurrent myocarditis in the VAERS safety mechanism. When you get the vaccine, they give you I've had the vaccine, you're given an app, and you just you have to log your symptoms every day, and they're pretty good at capturing stuff. So I think it's very, very likely we would have picked up myopericarditis if it was a side effect at all, and in with or without prior myocarditis. So I think it's very, very low, under 1 in a million.
Okay, that's good to know. Okay, Jack, there's a pediatric myocarditis question. They want to know if there's any new pediatric research being done in viral myocarditis.
There have been a couple of multi-institutional retrospective type studies that are ongoing right now, just collecting data about different types of therapies that have been administered and outcomes. Some of those data are still yet to be published. I am not aware of any prospective forward-looking studies in myocarditis in children specific to children at this time. That was kind of our goal with the biobank, was to be able to use specimens from patients and do different analyses specific to pediatric patients. And we're still working on that, tweaking that, and eventually we'll get there, but we're not there just yet.
Okay, there's another question about viral myocarditis, asking if you had viral myocarditis once, are you more susceptible to getting it again? My doctor says no, but I've heard from a number of people that they have developed it more than once. Do you have any ideas? Anybody on that?
Bettina or Delisa?
Yeah, I think it's rare. I've
Or both?
seen 1 or 2 patients myself. So the most of the patients I've seen had it the first time and only this one time.
Is there any new progress being made in a rapid diagnostic test for viral myocarditis?
I don't think it's any more rapid than what we currently have. The trouble is blood tests like antibodies against viruses are not terribly accurate when compared to viral genome analysis in the heart. And we don't do heart biopsies for most people with mild or even moderate myocarditis because they do well. And the risk of the biopsy would be overall greater than the potential benefit in a large number of people. So we don't, the short answer is we don't often make the specific diagnosis of viral disease. And although there are some, including Bettina, who's did a nice study, I think, of, and you may want to comment on your research paper on the agnostic approach to viruses. But right now, at least in clinic, we aren't doing anything new. Bettina, you had that recent, your paper came out, I think, last year.
So we wanted to see if we can find any new viruses that haven't been described yet in myocarditis, or if there's still presence of viruses when the patient develops myocarditis. So we've looked mainly at plasma and blood cells, also some tissue from giant cell myocarditis and a few biopsies, and screened them for all known vertebrate viruses that have been described so far, so several thousand of viruses, and there weren't really any relevant amounts of viruses that we could find, so no viral presence that could explain the myocarditis, which suggests that by the time when the myocarditis symptoms break out, which is usually 2 weeks after a viral infection, by that time the virus is not detectable anymore if it was ever there. So so it suggests that once the myocarditis breaks out, becomes symptomatic, the body has already cleared the virus, and it may be residual damage or ongoing inflammation triggered by some autoimmune mechanisms or overreaction of the immune system. That was our conclusion.
Yeah, so the virus often the viruses that cause myocarditis, they don't really target the heart per se. Most of them target other organs where they would replicate and make more virions the most. So Coxsackie virus, is a gut virus. So it really likes to replicate in the intestine, not in the heart. But what we have discovered and what we're doing research on is that it actually will go to the heart because mitochondria are there, and it uses it in its replication cycle. But it does not necessarily need to be there in very high quantities. So it can be there enough to cause a problem, but not enough to make it easy for us to detect that the virus is there, because really where it is in plenty of amount is in the intestine where we're not looking. And actually every one of the main viruses that cause myocarditis they don't have what we call a tropism for the heart. Their primary organ of interest is not the heart, but they go there to hijack the mitochondria. So that's, I think, why that has not been a very good way that we can detect anything. And that's part of what we're trying to understand what's going on. And the other thing that we've been working on, it's been kind of a slow moving project for a number of reasons, but mainly what we do is imaging tests, right, to understand and to diagnose myocarditis. And I guess the one advancement we have been able to make is we've been looking at a biomarker, a type of marker on immune cells that actually is a receptor on mitochondria in immune cells. And it's used commonly, radioligands are put against it to use in PET and scans. And so we were able to get IND approval to use this in patients. So now we're just looking to get some funding to do our first clinical study to test this in myocarditis patients. So hopefully we can get that going this year. And we might have it improved. Why this would be an improvement over past imaging is that most imaging is not directly detecting the inflammation, and this would be detecting it directly.
Okay.
And Jen, I'd like to we're at the halfway part right now, and I just wanted to say what you were saying to Lisa about how viruses often affect other organs first is reminded patients who have had, and the families who've been affected by myocarditis realize the frustration of finding accurate information, often more prominent in the lungs, like the SARS-CoV-2 virus affecting the lungs primarily, that people don't see the heart as being that important. And in general, myocarditis is eclipsed by the larger cardiac diseases, which are blocked arteries or ischemic heart disease or valve disease in rheumatic carditis. On a global scale, this is true, but those people who are affected by myocarditis, it's a big deal. And it's really important to understand it and not to realize that even though that myocarditis is a few % of all heart diseases, it's super important to the people who are affected and not to give up hope. There's the core group, the four of us and people like us who are really committed to myocarditis research, to discovering cures, and to not give up. There are people globally throughout the world who really, really care about this relatively uncommon, but not really rare disease. And with that, Jack, actually, speaking of rare diseases, Jack, could I just direct a follow-up question to you? We were talking about how myocarditis in the adult, older patients with pre-existing comorbidities is relatively uncommon, even if you're hospitalized. But there's another population of children who get an MIS-C syndrome, this multi-system inflammatory Kawasaki's-like syndrome. And there it's a little bit different. Although that's a rare syndrome, my understanding is that the rate of myocarditis or even coronary aneurysms is relatively high. Could you comment a bit for the people from a pediatric standpoint on that unusual but cohort of children and young adults?
Yeah, you're right. It is very unusual, and fortunately, it's not as rare as we'd like it to be. But this is an inflammatory response that happens generally a couple of weeks after the initial acute phase of COVID or the coronavirus infection. So it seems to be separate and distinct from that initial infection. And so it's this follow-up phase that happens a few weeks later, in which patients become acutely inflamed. They can definitely have myocardial involvement. We can see severe dysfunction of the heart muscle contractility. We can see swelling of the heart muscle on echocardiogram. As you described, there can be coronary artery involvement, including aneurysms or dilation of the coronary arteries. These patients also are at increased risk of developing blood clots. Like their adult counterparts, they can have severe lung disease as well. These patients are generally very, very ill. We've lost a few patients at our institution. Most of those had underlying diseases, however, but not all of them. And the good news is, however, despite the severity of the illness and its impact on the body, these pediatric patients have the capacity to rebound in a way that is just really remarkable. And so most of these patients go on to have some degree of recovery, if not complete myocardial recovery, after this inflammatory cascade event that happens a few weeks after the initial infection. We're following these patients long-term now. We're gathering as much data as we can to have a better understanding of what their long-term prognosis looks like. Some of these patients, we have found that they will have ventricular arrhythmias in follow-up. But like I said, most of them have recovery of their heart function and seem to do quite well and rebound after that acute phase. So it's bizarre, and I'm glad we're not seeing it in the same way in adults. But the good news is the prognosis is good, even in this group of patients.
I've had a number of questions related to supplements, the possibility of supplements to reduce inflammation and boost the immune system. Is there anything that you recommend people take, especially if they've had repeat myocarditis?
I can make a couple comments, and then of course, clinically, other people can. So mine would be from a research standpoint. So I just see that question there, and I see vitamin D as one of the things that are mentioned. So actually, when we did gene analysis of myocarditis, one of the main hits that we got as a pathway that's being affected during myocarditis is the vitamin D and vitamin D receptor pathway. So actually, it's not a vitamin at all. So it probably shouldn't be in the supplement section. It's actually a steroid. So it's something like estrogen or testosterone. And it really, just like those sex hormones, it influences the immune response very strongly. That's one of the reasons why we need to have a good vitamin D level, is so that our immune system will work properly. So I would say, we need to be careful not to have a low vitamin D, also not to have too much. Probably that's true with any supplement. Some of these things you buy in the store, they give these absolutely crazy levels of supplement. So always, have to be careful regarding that. But because it's a steroid, one of the things that we found is it also really differs by sex. And so this is ongoing research. We haven't published it, and we are looking both in people and we're looking in the animal. And it's very, very important, its effect on what's happening with inflammation and whether it's increasing inflammation or decreasing inflammation in a sex-specific way. I will say that if you have low vitamin D as a woman, just like for other autoimmune diseases or other conditions, that is not good as far as myocarditis is concerned, and we're still trying to understand it better. So the other thing that I would say is we think that mitochondria are very important in what's happening with myocarditis, but it's still a little early to know and be able to say whether, there's some new supplements that are out there or have been going for a little while, like ubiquinol for mitochondria, and recently True Niagen, which is NAD positive, which are very important for your mitochondria to work properly, your electron transport chain. And those, of course, are supplements that are available. So those are probably going to be important, very important, I would say, going forward. But it's still early days and we haven't done the research yet. So
I would
that
just add,
those are two things that are on the horizon as far as research is concerned. Go ahead.
yeah, that's great. That's great, Dilita. I would also add that, the question is what can we take or do or add to our lives to reduce inflammation? We can also remove things from our lives to reduce inflammation. So, for example, if you are a smoker, kicking the habit can help reduce inflammation. If you are a couch potato, getting off the couch and exercising can help reduce inflammation. If you're obese, losing weight can help with inflammation. If you're diabetic or pre-diabetic, that also plays a role in inflammation. So there's a lot of things that we can do without even having to take supplements that can help if we're one of those high-risk type patients.
Okay.
Very good point.
Sounds good.
Let's see. Someone wants to know,
Jen?
how do you know when you are out of the inflammation stage of myocarditis? And can you only see it on MRI?
Well, that's a great question. Let me say that there isn't a precise answer to begin with. That the initial phase of inflammation, the first couple weeks where you're peaking and you're upregulating, is easier to define both by biopsy and by MRI than it is in the more chronic phase, where the features of MRI overlap considerably with dilated non-inflammatory cardiomyopathy. And I think at a cellular, at a histologic level, it's not 100% uniform. So it isn't like the entire heart goes from normal to inflamed to scarred. It happens in islands and it happens regionally. And there are different diseases like sarcoid, for example, which is a kind of granulomatous myocarditis where it has certain patterns that might be more scar-based and different than certain viruses, for example. So I think that you ask a really good question that has confounded investigators clinically for a long time. And the work that Delisa described, looking at specific cell surface markers on macrophages or CD11 positive inflammatory cells, is going to take us to another level. What we have now in the form of PET scans and MRIs is pretty crude. It's pretty crude, and the spatial resolution is pretty poor. There's a technique that we use called endocardial mapping for patients who have myocarditis related to arrhythmias related to myocarditis. And we think the spatial resolution of that is better than MRI. And we have, we're studying that right now at Mayo in a enterprise-wide registry where we go back and look at all the people at myocarditis, MRIs, and endocardial mapping to see if we can improve in those people with arrhythmias diagnosis. So there were a couple other questions I just see here about transplant, and I thought maybe Jack and Bettina and I could just take these as a group. Maybe one is with lymphocytic myocarditis, do the answers to the giant cell or biomyocarditis closely relate to me, or is lymphocytic myocarditis a totally different condition? So that, and there are a few other questions about post-transplant issues in myocarditis. And I think it's a little bit different maybe in children, which is why I think, Jack, you have a more accurate perspective than I do on this. Back about 27 years ago, a guy named Jack O'Connell published a paper in the Journal of Heart and Lung Transplant, which is a very small number from a thing called the UNOS database, where he suggested that there was a greater rate of organ loss in myocarditis patients than those without. And that set up a lot of interest in the field. And so much larger studies in Canada and the US were done. And they basically showed that the chance of losing your allograft or dying after transplant was pretty much equal in the adults. This is adult patients with myocarditis or just a non-ischemic cardiomyopathy. And that took us up to about 15 years ago. And then Charlie Cantor from St. Louis published a paper, I think, in pediatrics I think suggesting that there could be a higher rate of rejection. Chantal Elam from Case Western, maybe 5 years ago, published a paper, again from this registry of all transplant cases in the US, that said that in giant cell myocarditis, you might have a higher rate of rejection, but overall organ loss was not any different. And so today, what I tell people is that the likelihood of dying or losing your allograft after transplant for viral myocarditis is not greater in the adult population, but I don't know what we say to children or parents of children who might be facing that, Jack or Bettina. I don't know what may be going on at Charité in Germany or the European Society of Cardiology perspective on transplant for myocarditis.
Well, with children, I think Jack knows better. Jack.
Yeah, I mean, we don't typically even, I don't know, we don't wring our hands about that so much. You know, as you know, the data are more limited in the pediatric side of things, and I don't know. I'm not sure what to make of that data that you're describing. If there is a difference, it's probably not a huge difference. And I guess I also am, you know, these are patients who are being transplanted for slightly different reasons, you know, and so are they, in general, just, are they sicker going in the first place, and is being transplanted for viral myocarditis, I mean, are you, when I transplant patients with myocarditis, they're generally quite ill. It's less often that chronic form of heart failure that we're dealing with. So these typically are not your status 2 patients at home, you know, who are waiting. They've been hospitalized for much longer. Their degree of illness is more severe, and so I think it's difficult to tease that out when you look at long-term outcomes in that population. So I don't typically, when I'm giving a transplant talk to a family, even delve into that to any great detail.
Thank you. And Bettina, for the European Society of Cardiology and the practice in Berlin, do you say anything differently for myocarditis versus non-myocarditis patients?
No, I mean, the ones that we've listed, they were urgent, so they were also very sick, and also I don't have any data on the differences there.
Yeah. So bottom line, for all those questions that came through about transplant, when we published our 1997 New England Journal paper on giant cell and showed there was no difference in outcome after transplant, all the data since are pretty much the same, that it's very, very similar for overall outcomes, with maybe some small differences in rejection or for giant cell recurrence rate, but it's not very, very rarely. In fact, in all my experience, there are only 2 people I can think of ever who lost an allograft to giant cell. So it's quite rare. So Jen, how would you like us to proceed? There are a lot of questions here.
Yeah, there's one more on giant cell, Les, if you wouldn't mind. It says Dr. Heidecker mentioned that immunosuppression, the vaccine may possibly lessen the effectiveness of making, I'm assuming they meant antibodies, but could it possibly cause a giant cell flare-up as far as...
I was waiting to answer this when I saw that. Yeah, we don't think that it could cause a giant cell myocarditis flare-up, but yeah, Leslie or Jack, if you want to weigh in, I could not imagine that it would.
The benefit of the vaccine is so much greater than the potential risk, is what I would say. Yeah. Recognizing that, of course, giant cell is very rare, and you know, the number and people on high dose immunosuppression were excluded from the trials. But having said that, Jack alluded to the ISHLT recommendation that you get vaccinated post-transplant. We certainly are recommending that at Mayo. And we would, I would not see transplant for giant cell as a contraindication to a vaccine?
Just one quick question, Les, on giant cell research. Is there any place that people, lay people can get the information on giant cell research, what's happening lately, or is it all in medical journals that people do not have access to?
The Myocarditis Foundation website and the chat rooms, what I try to do is forward everything that's coming out to Jen that I'm aware of that can be cited or referenced, and try and get that out to the public through the foundation. Of course, a lot of the cutting edge stuff occurs at medical meetings or in journals first, but ongoing trials, there isn't a trial on giant cells specifically, but clinicaltrials.gov is a great source of trial data for all registered trials. There are quite a few, there are a number going on in myocarditis, for example. That's where great source of information.
Okay. A quick question, Jack, on RSV. Is there a connection with viral myocarditis and RSV? I know RSV is a virus. Is that
RSV is respiratory syncytial virus. It's a common childhood viral infection, usually affecting toddlers, but also can affect really anybody, including adults. This virus has a special, it's called tropism, or an attraction for attacking the lining of the lungs. So those cells, and it can cause inflammation of the lining of the lungs and lots of mucus production and wheezing and tightening of the airways and even pneumonia in some situations. Is there a connection with viral myocarditis? Well, RSV has been implicated in some cases of pediatric viral myocarditis. I've seen it myself. So some patients can develop myocarditis from this particular virus, yes. But just because you had RSV in the past, does that make you at increased risk of subsequently developing myocarditis? We have no reason to believe that.
okay? I have another question that just came in. Do the benefits of exercising with scarring outweigh the risk? I'm assuming this person is suggesting after the doctors have recommended you go back to exercising, and the scarring still is present. Should you exercise, is what his question is.
Bettina would be the authority. For
Yeah,
everyone who doesn't know, Bettina wrote a paper that she led when she was in Zurich on exercise after myocarditis. And so you're the authority here.
It was important to us to do collect some data on this, because as we mentioned before, athletes, very commonly it affects athletes. They seem to be more receptive to myocarditis. And of course, it's hard for them to stop. And so we've done a small prospective trial where we will let them exercise again after 3 months if they had no ongoing symptoms or arrhythmias. And they were doing well. And sometimes there is a bit of scar that you can see also on MRI. Some of them did have that, and still there were no issues. We gave them 24-hour monitoring and exercise stress testing, echo after 3 months, again 6 months, and 1 year follow-up, and even 2-year follow-up. There were no complications. I think if the disease is stable, there's some residual scar, but there are no more arrhythmias, no more signs of ongoing acute inflammation, then definitely the benefits of exercise outweighs the risks, because there was a very interesting study that we found during our literature research. They've used students and they had them stay in bed for 1 week. And they were only allowed to get up half an hour a day for their daily hygiene. And they've shown that just after 1 week, the insulin resistance, which is the problem of diabetics, that they're not sensitive to insulin anymore, they lose sensitivity. The insulin resistance went up already after 1 week of inactivity. So yeah, that was very impressive for me to read that in students even, so they were not even having preconditions. So yeah, for sure. And you know, it's also getting you out of your routine, out of your exercise routine if you stop so long. So yeah, there's a lot of consequences.
Jen, I see that there's several questions that came in before we started, as well as on the chat, about recurrent myocarditis,
Yeah.
and specifically recurrent viral myocarditis. I'd ask the panel, I'd like to lead off a panel discussion, because there may be 4 or 5 of those that I see that have collectively come through. There's several related diseases. And I'm just kind of setting off the framework here. I think that we have viral myocarditis or autoimmune post-viral myocarditis in one bucket. And that has a certain histology usually, and it has a certain natural history that we've talked about, which is monophasic, usually with a tail, burning out into either a recovery or to dilated cardiomyopathy. And then there's this other disease, ARVC, or which is, in the last question came through, arrhythmogenic right ventricular cardiomyopathy. There's a left ventricular version too. And the term for that is kind of arrhythmogenic cardiomyopathy. Now it's moving away from what was a classic disease described by Frank Marcus in 1982, by the way, as in a very specific phenotype, and associated with gene abnormalities called desmosomal gene abnormalities, and another disease called sarcoidosis in the heart, which is a histologically very distinct thing, but it's hard to make the diagnosis. And so the 3 of these entities, which all can be on occasion associated with arrhythmias, have at times overlap. And not only do they have overlap, but they have times where there can be hot phases, where you get an ARVC that goes through a phase where it looks a lot like myocarditis, and then it goes down into a quiescent phase. There's actually a paper, it hasn't been submitted yet, from Northern Italy, which I'm reviewing, which has describes the use of immunosuppression. Actually, it was submitted, rejected, and now I'm reviewing it. But it was it describes the use of immunosuppression for ARVC, suggesting that you can have a very low rate of arrhythmias in that setting. A disease that is thought to be genetic, not inflammatory. And so the framework for the group I'm just describing is the old boundaries between these distinct entities seem to be blurring. And so recurrent viral myocarditis in the question may actually be a desmosomal gene problem. And maybe the virus is a trigger, or maybe incidental. I don't know. I'm curious to hear other people's thoughts about the spectrum of arrhythmogenic or recurrent cardiomyopathy today. Maybe Bettina, is there any discussion in Berlin
We
over these
recently had a
issues?
family who had a desmosomal variant, and interestingly, the mother had it too, and the 2 sons had it, and the 2 sons kept getting severe myocarditis each time they had a strong sports activity. So during a major soccer game, one of the sons had a major myocarditis with very highly elevated troponins in the 1,000 range. And then with rest and treatment, he finally improved after several months. And the other son also not as severe, yeah. And the mother didn't have any myocarditis. So she had the gene, but only the sons were affected. And we also published this, and it was a desmosomal variant. There was no viral trigger in that case, no obvious one. It was really the severe exercise, like a very special game where they gave everything. Yeah, it's very interesting. So there was also a desmosomal variant. Otherwise, I haven't seen any other examples in that area.
Yeah,
One of my
have something
family
very-
with go. No, I was going to say, the last patient I saw with a desmosomal gene variant and recurrent myocarditis, I saw 3 days ago. I followed him for a while, but his daughter and his father have the same gene mutation.
Yeah,
Jack?
I have a family very similar to that. I follow a teenage girl who's a student athlete who had a sudden cardiac event, had to be resuscitated, and we obtained an MRI on her, and her cardiac MRI just screamed myocarditis. It looked classically like myocarditis, however, with relatively preserved cardiac function, but just a lot of myocardial edema, hyperemia, what we would call fibrosis or early scar. And but we went ahead and sent gene testing on her just to be, thorough. And she had a desmosomal gene mutation. And so then we tested the family. Father had it as well. Father had always been healthy, never had any kind of problems. But this active student athlete who had this genetic mutation really was quite affected. We're still waiting to hear back. I think we tested younger brother. I haven't heard about that, but yeah, it's. I think we're learning a lot more about this, and I'm starting to hear from my colleagues similar situations.
Someone
We have a
asked,
paper at circulate. We have a paper at circulation. It's been there 12 days, so we think they sent it out for review. Hopefully.
someone would like that gene spelled out. I guess they want to look it up further. And how would you test for that gene mutation?
So there are multiple genes in the desmosomal, but DSP would be one, or desmoplakin. But there are multiple genes. And Jen, I see we're in the last 30 minutes here. We've had a great first hour and a half, and obviously from all the questions that are coming in, there's a lot of engagement. It sounds like people are hopefully are getting a lot out of this as well. We're not going to be able to answer all of the questions, but Jen, maybe after we're done, if there are a few that you could send out to us, we could answer them back to you by email or something, because I don't want people to leave feeling they were not heard. We've read all of them, but we may not be able, for time limitations, to answer all of them.
Okay, will do.
Here's another one about the COVID vaccine. It says, is one COVID vaccine better than another given this type of heart history? I would say, generally speaking, no. At least in the United States, the Moderna and the Pfizer have similar rates of efficacy and safety. I don't think there's a difference between those. And I don't see how that would be related to your heart history. The AstraZeneca vaccine, which has a lower efficacy rate, is being used in the UK and is not approved for use here yet.
And one quick question, the last one, my father passed away from viral myocarditis. Should I be concerned? The published papers so far, and there are 8 or 9 of them, looking at high populations where you have recurrent myocarditis or arrhythmogenic cardiomyopathy, have a 3.5 to 8% rate of gene mutations that were identified. But these are sick populations with multiple affected members or recurrence. And so I don't know that in the general population, it's going to be that high. So we don't recommend at this point gene testing. I think we need a couple more years of papers to come out before we can make a solid recommendation about that.
Yeah, so most viral myocarditis is going to be, the virus is going to initiate it. And so it's only going to be quite a small portion of that group that might have a gene playing a role.
Yeah, same in the patients we've screened.
Yeah. Like Bettina, in my clinic, I'm not recommending gene testing for routine myocarditis. If a family comes in where the mother and the son, or 2 children have had multiple episodes of recurrence, or it's an unusual phenotype where you've got a high rate of arrhythmias, which isn't really common in most mild viral myocarditis, then that's when I start thinking about a genetic cause and maybe get gene testing for cardiomyopathies, but not for routine. I just don't think I don't think that the general population it's there yet. Jen?
Yes. Did we go through all? Because I was busy writing down questions before. Did we go through all the questions that people had sent in?
Here's one about exercise. We've kind of touched on this a little bit. It said, when is it safe to exercise after COVID myocarditis? Generally speaking, the recommendations are similar to routine myocarditis or routine viral myocarditis, in that you shouldn't be participating in competitive or strenuous sports, I would say even recreational sports, for the first 6 months until you can be reevaluated. At our institution, that reevaluation would include another echocardiogram, plus minus a MRI, depending on what the first MRI showed. We would also perform a Holter monitor, a 24-hour EKG monitor, and usually, and this may be overkill, I know not all institutions are doing this, but if we have a student athlete who wants to participate in competitive sports, we'll have them run on the treadmill and do an exercise stress treadmill test before giving them clearance for that. So in general, no for the first 6 months.
I saw a question about, is driving a car after myocarditis okay? Yeah, so if there's no other contraindications, like patient had severe rhythm disorders that required to implant a defibrillator or things like that, if it's just the myocarditis, then there's no issue. So, no
There's a question that has Delisa's name written all over it about estrogen therapy increasing the risk of heart attack or myocarditis up there at from 11:38 a.m.
Okay, I'm just looking at it. So I've been told estrogen therapy for use in treating menopause increases your risk of heart attack, but for giant cell myocarditis, is it beneficial? So estrogen is really protective for heart disease in general. So we've done a lot of research on this. So it's one of our most protective things we can have for any type of heart disease or all the major heart diseases we're thinking of. Most of those heart diseases are more dominant in males, and the pathogenesis or how the disease develops is that estrogen protects against that. And so there's a lot of research showing that. Estrogen also reduces the amount of inflammation, the type of inflammation, so that the inflammation will respond to a viral infection, but then it will clear and go away afterwards, and it won't lead to remodeling or scar tissue being laid down. So that's some of the really protective effects related to myocarditis that can happen with estrogen, but that's during your regular female adult cycle. So what happens after menopause? Because so menopause, when your estrogen levels drop, one thing that estrogen does that is not beneficial potentially for disease is that it increases antibody levels. So we know if we look at regular autoimmune diseases, like rheumatic autoimmune diseases like lupus or rheumatoid arthritis or Sjogren's syndrome, those diseases have a lot of autoantibodies that that cause the disease, and estrogen actually promotes that kind of disease. And so when we're thinking of maybe autoimmune forms of myocarditis or forms that have to do with more mast cell activity or maybe more eosinophils, it is possible that estrogen could increase some of those cells. From our research, we haven't researched that as much. It just depends. It just depends on the context a lot with what's going on. And everything changes with menopause. So when the protective effect that you've had from estrogen up until you go through menopause and then the estrogen levels drop, well, that you still have antibody responses. So you see that you don't necessarily, get rid of that effect. And what you do is you become sort of more male-like then. So you can have an increased risk for inflammation that looks more like male disease. So if you're older, then you could have an increase in inflammation. but that's research actually that we've been working to get funding for, to really look at what happens in patients after menopause. Because we see far more males than females with myocarditis, that's been a little bit difficult. The numbers are lower in females, to try to get enough patients to really look at what's happening in females, both pre and post menopause, to understand what's happening in their inflammation. But we think that there is like a little bit of an increased risk after menopause as far as myocarditis goes, by looking at some biomarkers that we've looked at. So saying all of that, what about estrogen therapy? Well, estrogen therapy, it depends. That is a very difficult question to answer, because estrogen therapy comes in lots of different forms. It depends on if you have estrogen plus progesterone, if you have, there's many different sort of ways that it's given and routes that it's given. All of that affects the immune system in slightly different ways. So there has been some research that there could be problems, after with getting estrogen therapy, maybe increasing a risk of cardiovascular disease. Other studies have found, well, no, we didn't really see that increase. And I think it's because this is just very difficult to study because of all those differences that happen. Long story short, is it beneficial? So with giant cell myocarditis, would there be a problem? I would say, that we would have no research on that. And that probably the benefit, if you really need estrogen therapy and it's really in helping benefit you, that your chances of that really causing you a problem with myocarditis, I would say, is low from a research standpoint.
And from a clinical standpoint, as Lisa said, we have no data. It's never been analyzed, even in subgroups, and so the recommendations would be driven in part by the benefits for other reasons to your health from estrogen, which you'd talk about with your physician. We have about 15 minutes left, and there are lots of questions.
Asking about, should I have gene testing because her father died of viral myocarditis and possibly an aunt. So at what point, I know you mentioned if there's multiple people in the family, at what point would you suggest gene testing?
Again, on this call, we're not making specific therapy or management recommendations for individuals. But what I would say in general is that if you have a family with multiple people who died suddenly or who died of primary heart muscle disease or cardiomyopathy, maybe myocarditis, that you should talk about that with your cardiologist and somebody who, because there are certainly familial cardiomyopathies, ARVC is one of them, and there are certainly arrhythmogenic syndromes that run in families that are a cause of pediatric sudden death, and you should, if you have multiple affected close relatives, that's a good conversation to have independent of myocarditis. And there's another question here, a couple questions on what genes to test for. So there's a practical thing that although you can do a single gene test, and historically years ago, not so many years ago, when it was very expensive to do gene testing, we used to recommend that people would just get a single, you'd find like in hypertrophic cardiomyopathy, different disease, you'd test the proband and then you'd do specific gene testing. Now, the cost has gone down and most gene testing is available in panels from GeneDx or Mayo. And so although you can test, of course, for individual genes, we tend to just order cardiomyopathy panels, and I don't know about Bettina and Jack at your institutions, but I think the practical thing is that they can test 70 genes for about the same time and cost as 1 or 2 genes. So I just order gene panels for cardiomyopathy that includes all the desmosomal as well as dilated and hypertrophic cardiomyopathy genes. What do you guys do?
We as well, because I think especially in these times, it's important to do that because we're all still learning. There's so many variants that we don't even know about yet.
We're in the
So
Myocarditis Foundation.
it may help the patient
Yeah,
directly
we have
by
70 people.
finding a
Yeah,
variant
well,
that we may
we
not have
10 more.
suspected because information is
But you can do
still
my
limited.
but we're
And
I won't
also
be
it
off till
helps the
11,
progress
11:05.
overall in science. But I think also quite often we may find a variant that we didn't expect because the knowledge on what those variants do on the phenotype, how they affect the phenotype, the disease is still limited. So we also go for a more comprehensive evaluation when we do genetics. Yeah, like you, Leslie.
Yeah, I would agree with that. We would do something very similar.
Yeah.
It's gotten so inexpensive, if not free, for our patients to undergo gene testing.
Yeah.
Broad panels, dilated, hypertrophic cardiomyopathy, ARVC panels can all be sent. I agree with Les. I wouldn't routinely send gene testing on a run-of-the-mill myocarditis, if there is such a thing as that. But if you had a sudden death event or a family history of a sudden death, that would, I think, push me to do further investigations, including gene testing.
So I think that pretty much, I will review the questions and see if there's anything in particular that we did not get to answer and direct it to the panel. But I just would like to take this time to sum up everything. And I think that it was a very interesting and informative session. I would like to thank all the doctors for sharing their knowledge and expertise with us on these subjects. I would also like to thank everybody for participating today and sharing your questions, as I imagine that many of us had the same questions that you were kind enough to submit. While COVID-19 was new for 2020, along with COVID myocarditis, many of us have known the word myocarditis long before this. We at the foundation them as well, but we're looking at raising awareness for the word myocarditis this year and to help people understand exactly what that means. I have spoken to so many people and they say, oh, who do you work for? And I tell them and they were like, well, what's that? And I would say, well, have you heard of COVID? You know, the athletes some of them have developed myocarditis. And they were like, no, I haven't heard any of that. So we need to make sure that people understand the word myocarditis because possibly it may help save a life for someone to ask about it or think about it. And it's our plan right now to bring awareness about the disease by using that word so that hopefully anybody that is potentially affected by it could possibly be diagnosed. Now, I just want to say that myocarditis is not an easily diagnosed disease. I just want to put that out there. And there is no single diagnostic test for it, but you heard from the professionals here how they go about testing and what is going on. If you are interested in becoming a volunteer or an ambassador to help us spread the word about myocarditis, please contact our office and we would love to hear from you. At this point, I would like to share the screen of the company that has so kindly sponsored our talk today. It's the Trilogy Group at Morgan Stanley. And we are planning on having several more meetings such as this throughout the year. The foundation relies on the help of donations to carry out our mission of education, research, and emotional support for those that are affected by the disease. We have sponsorships available at several different levels. Perhaps you know of a business that might be able to help us in the future with a future meeting where their help will be advertised over and over on our website and YouTube channel, as these will be posted there. I just want to put out that last month we had over 40,000 new users that came to our website to learn about this disease. So I think that it is a worthy cause to donate to. I can't think of a more worthy cause than the Myocarditis Foundation. The video on this program will be available on our website and YouTube channel, hopefully within the next week. And we wish everyone a happy and healthy new year. We thank the doctors again for their time and expertise. And we hope that you enjoy the rest of your day. With that, if anybody has any questions from the panel that you want to also say, Dr. Cooper or anyone, please feel free. We have a few minutes.
I want to thank Jack and Bettina and Delisa for taking 2 hours from their morning or afternoon, as it is in Berlin, for this activity. I think what your contributions were invaluable. I know that many of the people on this Zoom call really appreciate the time and effort that you made to contribute. Thank you so much.
Thank you, everyone. Enjoy your day, and I look forward to letting you know when our next meeting will be. Have a good day. Take care now. Bye-bye.
Bye.
Take care.
Bye-bye.